Today I'm going to be talking about immunotherapy side effects and management, just a brief overview. So what I mean by immunotherapy is specifically three classes of drugs. So you have your PD-1 inhibitors, examples of which are nivolumab, pembrolizumab, cemiplimab, and dostarlimab. And then your PD-L1 inhibitors, examples of which are atezolizumab, avelumab, and durvalumab. And then we have another class of medications called your CTLA-4 inhibitors. Most commonly are ipilimumab and tremelimumab. So how does immunotherapy work? At a very basic level, your cancer cells upregulate certain proteins called PD-1, PD-L1, and CTLA-4, along with some other proteins. And this masks the cancer cell, preventing the immune system from destroying the cancer cell. So the way these medications work are they bind to those specific protein and thereby unmasking the cancer cell, allowing the immune system to attack the cancer cells. But in normal healthy cells, also we have PD-1, PD-L1, and CTLA-4, which prevents normal cells from being destroyed by the immune system. So with immunotherapy, given that this is also potentially binding to regular cells, you can have side effects from them by increasing T cell activity, increasing levels of autoantibodies, release of inflammatory cytokines, and also complement can also be upregulated when it comes to CTLA-4 antibodies, which can also cause immunotherapy-mediated side effects. So almost any form of itis is possible with immunotherapy, as demonstrated in this picture here. But fortunately, your bad, life-threatening, rare side effects like myocarditis, encephalitis, nephritis, and hematological toxicities are pretty rare, constituting less than 5% of the overall immunotherapy-mediated side effects. So coming to some general principles across the board, you always want to rule out other etiologies of the patient's symptoms before considering this being immunotherapy. So infections, medication toxicity, so on and so forth. So it's important to note that every organ system has its own grading systems, grade 1 through 4, for immunotherapy-mediated toxicity. We'll go over that in a bit. But in general, your grade 1 immunotherapy-mediated toxicities, patients are typically asymptomatic or have mild symptoms. And in that situation, we actually just continue the immunotherapy with close monitoring for adverse events, and we manage them symptomatically. For your grade 2 toxicity, which are moderate toxicities, we hold treatment. And if the patient's symptoms do not resolve, we typically initiate glucocorticoids at a dose of 0.5 milligrams per kilogram of prednisone or equivalent if their symptoms do not resolve within a week of holding the medication. For grade 3 or 4 toxicities, these are severe or life-threatening toxicities. A lot of times patients need to be admitted to the hospital for management. We permanently discontinue immunotherapy, and we need high doses of steroids of about prednisone 1 to 2 milligrams per kilogram or its equivalent. And we only start tapering when symptoms subside to like grade 1 or less. And we typically do a long taper over about 4 to 6 weeks. When it comes to refractory toxicity that from immunotherapy, fortunately, it's pretty rare. Most patients respond to steroids within a week. And if they do not respond to steroids within a week, then we should definitely consider second line immunosuppressive agents. And there are no clear cut guidelines on what to do in each situation, but we typically use organ specific immunosuppressive agents. So, like people who are having colitis from immunotherapy, we typically use infliximab or Remicade or Entyvio, so on and so forth. And your immunosuppressants in the second lines are typically T cell suppressing agents like mycophenolate and so on. The exception to the rule is kind of grade 2 endocrinopathies. This is hypothyroidism, hypophysitis, adrenal insufficiency, and treatment is aimed at basically that particular steroid replacement. So if they develop hypothyroidism, we just replace with levothyroxine. If it's adrenal insufficiency, typically hydrocortisone and steroid replacement. And we closely monitor these levels almost every 3 to 6 weeks whenever someone is on immunotherapy. So, why we try to jump to using steroids in patients with immunotherapy mediated side effects is that we know that a use of 10 milligrams of prednisone or more is associated with poorer cancer outcomes. And we try to avoid using steroids as much as possible, but obviously if we need to, we need to. So I'm going to go over the four most common ones that we may come across: pneumonitis, colitis, hepatitis, and dermatitis. So coming to pneumonitis, like I said, the first thing we always want to do is rule out other etiologies of the patient's symptoms. So we want to be doing pulse oximetry, doing a CT chest to rule out pneumonias, viral studies with PCR, blood cultures, sputum cultures, so on and so forth, and take it from there. Typically, grade 1 toxicity or pneumonitis is just an incidental finding on a patient's CAT scan. So we may see some radiological findings like infiltrates on their CT scans, and they're completely asymptomatic. In that situation, we just continue their immunotherapy. Similarly, in grade 2 toxicity, we typically do hold their immunotherapy and monitor for symptom resolution. If not, we initiate prednisone. Grade 3 and grade 4 toxicity, patients are typically oxygen dependent and require stress dose steroids like we described before. Similar to pneumonitis, with colitis, you want to do all your stool investigations, C. diff testing, ova and parasites, your stool culture. And if they're having less than 4 bowel movements a day, we typically just use antidiarrheal agents. But grade 2 onwards, we typically hold immunotherapy and use steroids. And like discussed before, if patients are not responding, we go to second line immunosuppressive agents. When it comes to dermatitis, your grading is typically based on body surface area. For grade 1 dermatitis, it's typically less than 10% of the body surface area that's involved. And we try to just do topical steroids and creams and continue the immunotherapy. Grade 2 involves over 10 to 30% of the body surface area. And then we most likely, if cannot be covered by topical steroids, we also need to give systemic steroids. And anytime you see bullous pemphigoid or like bad maculopapular rash, that would be considered grade 3 toxicity onwards, and they need high dose steroids like we discussed before. When it comes to hepatitis, your grading is based on the level of LFTs. So AST or ALT up to 3 times the upper limit of normal, provided the patient is asymptomatic, we just continue immunotherapy. For asymptomatic patients with your LFTs at the level of 3 to 5 times the upper limit of normal, we typically just hold and monitor them. But again, if your LFTs are above 5 times the upper limit of normal, we need to typically permanently discontinue the immunotherapy and treat with systemic steroids. So yeah, this is kind of just a very brief overview. Wanted to leave like 5 minutes for questions if anyone had any questions.
I have a question, Dr. Mettu. This is Stephanie Hills. Can you hear me?
Yes, I can hear you
Okay.
clearly.
So if just because I'm not super familiar with all of these, obviously we don't prescribe them in surgical oncology, but we, see patients with these with the side effects. But if a patient fails one particular agent because of like a grade 4 um, adverse event, does that exclude them from immunotherapy, like period moving forward,
So that's a
or is it
great question.
drug specific?
That's a great question. I mean, obviously we want to treat their cancer. There's really no clear data or evidence to suggest switching from one agent to the other. I have personally tried that in the past, and surprisingly, patients respond differently and react differently to different agents. So, if they were having like a really good response to their original agent, but they had to be discontinued, I would probably re-challenge them with another agent. But that's a very nuanced question, and how bad were they? And like, it's really a informed discussion that we have.
Sure. Okay. Thank you.
Any other questions? All right. Thank you for everyone's time.
Thank you so much, Dr. Mateo. It was great.